to the part 2 of our session with Aditi ma'am. Handing over the session to you, ma'am.
I would like to welcome you all. So in the last session, we have seen about the normal oxygen transport and the steps involved. So today we'll be discussing about factors that actually perturb the oxygen transport in terms of few physiological conditions and few pathological conditions. Cyanosis is bluish discoloration of the skin and the mucous membrane. So the cyanosis again can be central cyanosis or peripheral cyanosis. So the reasons could be arterial hypoxemia or hypoventilation, pulmonary shunting, stagnant circulation. Again, we have seen it in detail, and decreased oxygen concentration of inspired gas. So high altitude wherein the concentration itself is less, that can also result into cyanosis. Now let's talk about relationship between oxygen delivery and oxygen consumption. So the normal resting values, oxygen delivery is around 1000 ml per minute and consumption is around 250 ml per minute. The extraction capacity of tissues is around 25% and mixed venous saturation is around 70%. Next concept is supply independent oxygenation. So supply independent oxygenation refers to a physiological state where tissues oxygen consumption remains relatively stable. Okay, so even when the oxygen delivery increases, it means that the tissue can maintain its metabolic needs despite a reduction in the oxygen supply. So, okay, so that is why it is called as supply independent oxygenation. Whereas supply dependent oxygenation, it occurs when a tissue's oxygen consumption becomes directly tied to the amount of oxygen delivery. Okay, so that means if the oxygen delivery, when it fails below the critical level, oxygen consumption will also drop significantly because of insufficient oxygen availability. So that is called as the supply dependent oxygenation. Previous slide, please. So under normal conditions, normal physiological conditions, most of the tissues are in the supply independent state where they can extract enough oxygen from the blood to meet the metabolic demands even when the blood flow slightly decreases. So that is when the state is supply independent oxygenation. When the oxygen delivery falls below critical level, okay, so that is around 550 ml per minute, tissues transition from supply dependent state, meaning that their oxygen consumption becomes directly limited to the amount of oxygen that is available. Okay, so this is seen in severe cases of shock or critical illnesses like ARDS, where blood flow is significantly reduced and tissues can then become supply dependent, leading to tissue hypoxia. Next slide. Okay, so supply independent, as we have just seen, it is above the critical level. Supply dependent is below the critical level. So in case of supply independent state, the oxygen delivery will decrease, but the oxygen consumption is still maintained. That is why it is independent state. Oxygen extraction will increase and the mixed venous saturation will decrease. Okay, but there is no evidence of anaerobic metabolism till the point where it is supply independent. Now, when the levels drop down below the critical level, it changes to supply dependent mechanism, wherein the oxygen delivery is going to decrease. When the oxygen delivery decreases, the oxygen consumption also significantly decreases. So there is a state of hypoxia. There also could be a state of increased blood lactate and ultimately resulting into organ failure. So initially it is supply independent, and then if the critical level is reached and if it further drops down, it might reach a state of supply dependency. Next slide. So the principal stores of body oxygen are the lungs, wherein while breathing air it is around 450 ml, while breathing 100% of O2 it is 3000. Next is blood, it is 850 and 950. Whereas in case of dissolved in tissue fluids, it is only 50 in case of breathing normal air, and when while breathing 100% O2 it becomes 100, and combined with myoglobin it is around 200 ml, and in case of breathing 100% O2 it is 200 again. Next slide. Now let's look at factors that contribute to or threaten oxygen transport. So it will all depend on the underlying pathophysiology or underlying conditions. Recumbency and restricted mobility is further going to put oxygen delivery system into danger. There are external factors related to patient care and internal factors related again to the individual patient. Next slide. So let us see the steps and the factors associated that can prove as threat to the steps in O2 transport pathway. So central control of breathing whenever the patient is under GA or there is pharmacological depression. So at this level, it can affect the O2 transport. At airways level again, if there are any chances of aspiration or if the patient has aspirated, that is how O2 delivery can be hampered. In case of lung, any etiology or any pathology that can result into acute lung injury, it can hamper the oxygen transport. Blood, the major factor is anemia because hemoglobin is the basic oxygen carrying mode. That is why anemia will affect again the O2 transport. In case of gas exchange, again atelectasis, when the underlying segment or underlying lobe has gone into collapse, it is further going to affect the oxygen transport. Next, respiratory muscles again. One of the example is after the patient has undergone abdominal surgery. Next slide. For abdominal surgery, the respiratory muscles will not be that efficient or will not contract to that level in order to increase the O2 transport. So that pose a risk of or deficit in O2 transport. Myocardial perfusion, any events of coronary artery occlusion will affect the O2 delivery. Heart again, conduction defects. If the conduction defect, there are conduction defects, the ventilation will again go down. Blood pressure again in cases of volume excess will affect the oxygen transport. Next is tissue perfusion. Again, impaired cardiac output. We have seen the state of stagnancy. Whenever there is stagnancy, the tissue perfusion is also going to go down, or whenever there is fluid volume excess, for example, in cases of renal failure, or when there is fluid volume deficit, for example, hypovolemia. So, hypovolemia can be because of any reason, road traffic accidents, shock, burns, anything. State of hypovolemia can actually affect the oxygen transport. Tissue oxygenation again, impaired gas exchange at the cellular level can also affect O2 transport. Okay, next. So now let us look at few conditions or few states that can affect the O2 delivery system. So effects of aging, there is increase in the lung volume. So that is called as senile emphysema. There is increased closing volume. There is also V by Q mismatch that is seen. There is decrease in the vital capacity by almost 30 ml per year. Okay, so all these factors can contribute towards the deficit in the oxygen transport. There is also decrease in the blood volume, decreased ventilatory response to hypoxemia and hypercapnia. So because all these mechanisms are affected, any deficit in the O2 system or any issue with any one of the step in the oxygen transport can affect the elderly more than it can affect the adults. Next, effect of, so I have just listed down few basic pointers that might help. So effect of obesity, again there is poor basal ventilation. We all know in case of obesity there is difficulty or there is no much space for the diaphragm excursion, and that results into poor basal ventilation. There is poor lung compliance, again V by Q mismatch can be seen, which will eventually result into hypoxemia. And breathing pattern is again rapid, shallow, and it is more of apical. Okay, so in case of obesity. Next, effect of pregnancy. So 20% increase in oxygen consumption to serve that extra metabolism is seen in case of pregnancy. 40 to 50 percentage of increase occurs in the minute ventilation. There is decrease in the PCaO2. The lung volume decreases. Vital capacity is maintained, but at the cost of increased work of breathing. So the RR will go up because tidal volume is not going to change that much. So all the entire onus is placed on the respiratory rate. So there will be increased work of breathing and the patient might experience dyspnea. Next. So effect of exercise. So oxygen delivery, consumption and extraction. All these three processes increase when the person exercises. So ventilation can increase from 6 liters to as high as 200 liters per minute. Again, depending on the duration and the intensity of exercise. Cardiac output can also increase fourfold. The systolic blood pressure increases in proportion to the oxygen consumption, but the diastolic blood pressure will increase very slightly or it will remain constant because of the peripheral vascular resistance. The diffusing capacity will also increase and the vascular resistance is going to drop down. That is why there is no much change in the diastolic blood pressure. So till now, whatever we discussed were the normal physiological conditions that or the effect that these four normal physiological conditions can have on the oxygen transport. Now let us look at few pathological conditions and the effects that it can have on the system. So in cases of pneumonia at mitochondrial level, the oxygen extraction increases. At tissue level, the oxygen hemoglobin dissociation also increases. At heart level, again, as I told you, whenever the ventilation is affected, whenever the ventilation, the perfusion goes in for a toss, the heart rate will increase in an attempt to increase the cardiac output, because of which the work on the heart is also increasing. In case of airways and lungs, there will be bronchospasm that will be seen. The mucociliary transport also will slow down. Because of that, there is going to be mucus accumulation and mucus obstruction. The resistance is going to increase because of bronchospasm. Compliance of the lung is also going to decrease. Inflammatory response will also be triggered, which will also result into alveolar congestion. There could be consolidation or atelectasis or pleural irritation. So the person might experience dyspnea, or there will be increased work of breathing, but the diffusing capacity is going to decrease. Okay, so any issues with ventilation or perfusion, it is basically going to put more demand or more workload on the heart and the lungs in order to pump better or in order to function better. So the RR also increases and the HR also increases in an attempt to maintain the cardiac output and to maintain the minute ventilation. So next is chronic airflow limitation. So in case of such conditions, the mitochondrial level oxygen extraction will increase. The oxygen hemoglobin dissociation will also increase. In case of heart, the heart rate will go up, but the cardiac output will not be able to maintain after a particular period of time. Then the work on heart is also going to increase. There could be RV dilatation that is seen in the long-standing respiratory conditions. The stroke volume is also going to decrease, and the right ventricular hypertrophy can also be seen. So in any long-standing respiratory conditions, these are two more important features that can be seen. That is the right ventricular hypertrophy and right ventricular dilatation. So as far as airways are concerned, there again will be bronchospasm. Because of bronchospasm, the resistance is going to go up. It is going to affect the mucociliary transport. There will be impaired gas exchange. Flattened diaphragm is already seen, which because of the altered length tension relationship is further going to increase the work of breathing. Hypoxic drive to breathe is there. Hypercapnic is already lost in these patients. So respiratory muscle strength and endurance also gradually decreases, and prolonged expiration because of the air trapping and hyperventilation. Next slide. ARDS, again, it is a very important condition. So anaerobic metabolism is going to go up because there is lack of oxygenation. So the tissue oxygen demands also increases, but because again the supply and demand are not able to meet, the anaerobic metabolism increases. Heart rate will increase. There are chances of dysrhythmias. The pulmonary artery pressure is also going to increase, and so is the PCWP. As far as airways or lungs are concerned, there is going to be bilateral infiltrates that will be seen. Inflammatory markers will be triggered. The volumes and capacities will go down. Cough reflex is also depressed or suppressed. The compliance is also going to go down. There will be V by Q mismatch that will be seen. Mucociliary transport will also reduce. That will cause mucus retention. Alveolar capillary membrane, basic causes alveolar capillary membrane leak that is present. So bronchial irritation can also be seen, and bronchospasm can also be seen. Next is lung resection. Lung resection, again, the O2 demand is going to go up. There could be hemodynamic instability. Airway closure is going to, there is going to be more of airway closure. Mucociliary transport decreases. The chest wall is going to, the excursion of chest wall is going to decrease. When the excursion of chest wall decreases, the bucket handle, pump handle movements are affected, and thereby the air entry, and again the ventilation part goes down. So breathing at low lung volumes will be seen. There will be increase in the work of breathing, increase in the closing volume. Weak cough can be seen, and monotonous tidal volume. So lower than shallow breathing will also cause monotonous tidal volume. Next is in case of MI, there is increased oxygen extraction that can be seen at mitochondrial level. The oxygen hemoglobin dissociation is seen. Again, tissue perfusion will go down. Aerobic deconditioning will occur, and oligouria can be seen. There could be ischemia, or there could be irreversible damage that can be seen in case of the heart muscles. Dysrhythmias can be there. Cardiac output is going to go down. The stroke volume is going to go down, and myocardial oxygen uptake will increase. Okay, and that can also we can also see ventricular dyskinesia after an MI. So airways again, there will be interstitial edema, pulmonary edema, or in worst cases atelectasis can also be seen, and increased work of breathing will be there. Next, in post CABG again, the kidney perfusion goes down, urinary output goes down, oxygen demand increases. In case of heart again, the work of heart is going to go up. There could be dysrhythmias. Airways again, there is going to be decreased mucociliary transport, decreased ciliary motion, or there could be restricted chest wall motion again because of pain. Patient is not going to breathe in deeper. There could be monotonous tidal volume breathing or breathing at low lung volumes. Thereby, the lung compliance is going to go down and the work of breathing is going to increase. More or less similar changes are seen in case of abdominal surgery. Next slide. So here again, encroachment of the diaphragm and related descent can be seen. Next slide. In case of head injury again, here the difference is with the ICP. So ICP is going to go up, cerebral perfusion is going to go down, the systemic metabolic demands are going to increase, and the oxygen uptake is going to decrease. So all this is going to put an extra added load on the heart. So the work of heart is going to increase. The cough reflex is suppressed in case of head injury patients. The mucociliary transport is reduced as there are chances of aspiration, atelectasis, or again acute lung injury. The lung volumes and capacities go down, the FRC goes down. There is also increase in the closing volume, which will further cause collapse, and monotonous tidal ventilation is seen. Okay, so we have seen few the effects of few physiological conditions like obesity, aging, pregnancy, and exercise on oxygen transport. We also saw the effects of few pathological conditions like head injury or CABG, abdominal surgery. How can that affect the oxygen transport? So far we have covered the normal steps of oxygen transport. Then we saw how can few physiological or few pathological conditions affect every step, each or one of each step in the oxygen cascade. But any one alteration in any one step of the oxygen transport pathway is going to increase, or it's going to put V by Q mismatch at danger, and thereby causing changes in the saturation. Now let's look at few of next slide. Let's look at few physiotherapeutic techniques which play a very important role in oxygenation, and it can have a significant effect on V by Q matching. So the ventilation goes up. If the perfusion is going to be better, that will ultimately cause increased V by Q matching, and thereby the saturation will pick up. Next slide. So we are not going to go into detail, just a brush up on the basic techniques that can have a role in oxygenation process. So these are all the lung expansion therapy techniques that we all have. So incentive spirometry, both flow and volume. Volume has better effect on the ventilation process, but yes, spirometry can help to improve the ventilation and thereby the oxygenation. Positive airway pressure adjuncts or positive airway pressure therapy, intermittent positive pressure breathing technique, or some lung recruitment maneuvers either in ventilated patients or non-ventilated patients. All forms of breathing exercise, all the inspiratory breathing exercises like thoracic expansion, segmental expansion, diaphragmatic breathing, all these things can cause increased excursion of the diaphragm and thereby increase the ventilation. Then there are also few PNF techniques like intercostal stretch, abdominal co-contraction, posterior, anterior stretch, posterior basal lift. These can also play a very important role in improving the oxygenation. And most important and most underrated is the positioning and mobilization. So we must always aim at early mobilization. Even if you cannot mobilize the patient out of bed, mere changes in positioning from supine to quarter to supine or side lying can also bring about a great change in the V by Q matching. So early mobilization or positioning has a very important role in improving the saturation. So body positioning again, as we discussed, so various positions like upright, supine, or side lying, prone, and head down position. So all these positions, if we look at the pathophysiology of the disease and the physiology of each of these positions and the right matching, if we are able to do it, it can definitely help in improving the V by Q matching. Next slide. So again, every single position has its different effect. So prone, supine, Fowler's position, Trendelenburg position, right lateral recumbent, and left lateral recumbent. So as I told you, even if complete upright, bedside sitting or standing or ambulation is not possible, a mere change of positioning from supine to quarter to supine or to side lying or prone or quarter to prone can also bring about a significant difference in the V by Q matching. So this body positioning is one of the most important techniques that can help to improve the V by Q matching. Oxygen therapy, again, we as physios might not be directly manipulating the O2 settings, but we need to know about the different O2 therapy devices. Next slide. So broadly, it can be classified into low flow and high flow. So under low flow, we have non-rebreathing mask, partial rebreathing mask, nasal cannula, and simple face mask. So it is better to know the FiO2 for all these devices, the advantages and disadvantages of each of these O2 delivery devices. High flow systems, next slide. High flow systems can be classified into a Venturi mask and the large volume aerosol systems. So again, if you are working, next slide, if you are working in ICU setup, it is better to know about the FiO2 deliver about for all of these Venturi devices. Next slide. Sorry, large volume aerosol systems again can be divided into high humidity TPs or high humidity tracheostomy mask or high humidity face tent or high humidity face mask again. So these fall under the high flow systems. Next, so this was all about the oxygen delivery systems, and last but not the least, the exercise prescription. So we have seen the energy systems in detail. We have seen how the different three energy systems that come into picture depending on the duration of the exercise and the intensity of the exercise. Next slide, please. So we have seen ATP PCR, we have seen the anaerobic glycolysis system, and we have seen the oxidative system. So depending on what type of training you want to give to the individual or to the patient, you need to design your exercise program accordingly in order to improve the oxygenation and the V by Q matching. So it should be, please go to the previous slide. So whenever we are prescribing exercise, it should depend on the energy system that we want to target, and of course the sports specificity should be considered. So whether you are training the individual for short duration, high intensity activities, or you are training the individual for long duration and moderate intensity activities will determine as to which type of training should be focused on. So yes, next slide please. Next slide. So to summarize again, we have seen the oxygen transport system. We have seen different terminologies that contribute towards the oxygen transport system. We have seen factors that affect the oxygen transport system. We have seen the physiological conditions like obesity, pregnancy, elderly population, and exercise most importantly. How can that perturb the oxygen delivery system? We have also seen few of the pathological conditions that also can pose a big hazard to the oxygen delivery system. And we have also seen few of the physiotherapeutic maneuvers or physiotherapeutic techniques that can surely help to increase the oxygenation and the V by Q matching in patients. So now next slide, these are the references. Yeah, next slide. Yes, so I would like to thank you, PhysioTV Sancheti, for giving me this opportunity for talking on this topic. Thank you.
Thank you so much for joining us, ma'am. The pleasure is all ours. I had a quick question, ma'am, because we talked about the normal physiological changes during obesity, pregnancy, and geriatric, as we work in all three domains
Right.
constantly. Do you think there are any specific precautions that we should take in consideration to the oxygen dissociation when we are treating such patients?
Yeah, so one quick implication that I can think of is monitoring the patient's saturation, because like partial pressure of oxygen will require ABG, VBG to be monitored, right? But that is not possible when we as physios are giving our treatment. So it is a good idea, in especially in vulnerable populations, to keep a check on the oxygen saturation, because more or less it will it will reflect the PO2 levels of this patient as well. So it is better to monitor. Again, second effect that we can think about is the drastic changing in positioning. positioning, especially if the patient has been in recumbent position for a very long period of time. There is hemodynamic instability that is there. Also in elderly also for that matter. Like when you make them exercise or when you make them get up or when you are going to change their position, it has to be gradual and no sudden changes in position should be encouraged. And yes, saturation monitoring is in vulnerable population is an important factor.
Thank you so much, ma'am, for joining us today. It was a
Thank you for
pleasure to
having me.
host you. I
Thank
would
you.
also like to take this opportunity to thank our management, Dr. Sancheti and Manisha Sangvi, ma'am, our director. I would also like to thank our principal, Purushimpi sir, for providing us with such a beautiful platform. I would also like to thank the Physio TV technical team who makes sure that the whole thing is run smoothly. And lastly, but not the least, our Physio TV viewers, without whom we would not have existed. Thank you so much, ma'am, and our dear viewers. Thank you.
Thank you. Thank you for having me.